So we're going to talk about vertebral compression fractures. And there's several different types, but primarily, this is geared towards postmenopausal women who have osteoporosis, which is really the large majority of compression fractures that we see in our practice and that we treat and that Scott also treats. So a compression fracture is basically what it sounds like. The vertebral bodies are the bones that make up your spine, and a compressive load causes the vertebral body, which is the front of the spine, to collapse down or compress down. And typically there's an associated forward curvature of the spine of some degree that goes along with that. And that can happen from trauma, it can happen from tumors, it can happen from osteoporosis, but most commonly it's a combination of osteoporosis and trauma to some degree. So women are 2 to 3 times more likely to experience a vertebral compression fracture as compared to men, and as Steve Hinman talked about, menopause and decreased estrogen and osteoporosis is the reason. And as you get older, there's an increased risk of fracture, malnutrition, weight loss. Oral glucocorticoids, prednisone, steroids really increases your risk, and that's really a big problem that we see a lot of. So in terms of spine anatomy, just a little primer. The spine is the thing which allows you to stand up straight, allows you to bend, to twist, and also protects your spinal cord and the nerves which come from your brain. And it's composed of 7 cervical vertebrae, 12 thoracic, and 5 lumbar vertebrae. And basically, those bones stack up on each other to form your spine with the discs, the cartilage joints in between. And the vertebral body is the bulk of each vertebrae. It's the front part that bears most of the weight, and that's what the discs sit on. The posterior elements are the pedicles and the lamina, the facet joints, the spinous processes. So if you have a compression fracture, by definition, it involves the vertebral body and not the posterior elements. And by definition, really, there's no nerve compression associated with it. So if you have nerve compression or bone pushing into the spinal canal, then you're dealing with a burst fracture, which is a different thing. And in terms of imaging, how we image this, X-ray, very easy, do it in the office, takes a minute. It's easy to see an obvious fracture like this one, but it may miss a lot of fractures, so it's not really a great test. MRI is the test of choice. The STIR image is the best image because it shows acute fractures, and the white signal in the vertebral body shows an acute fracture. That's marrow edema, which is what you see with an acute fracture. And an acute fracture is a new fracture. Chronic fracture is a healed fracture, which is generally 3 to 6 months old, and once a fracture is healed, the MRI looks like a normal bone signal like any other bone. So you can tell with an MRI acute from chronic, which is excellent, and it's very sensitive. It shows you the nerves, nerve compression, but patients don't like it. People are claustrophobic. It's painful to lay there for half an hour. It's expensive. And if you have a pacemaker or some other implant, you can't do an MRI, and that's actually very common in the population we're treating. So CAT scan is a good test. It's excellent for bony detail to show you the fracture. It doesn't show you the nerves. You can do it with a pacemaker. But you can't differentiate acute from chronic fractures generally, although you get some hints. A bone scan is a nuclear test where you inject a radionuclide, which is followed by imaging, and any area where there's a fracture in the spine or anywhere in your bones will light up because of increased metabolic activity. And so we'll do that in combination with a CAT scan when we want to figure out if someone has an acute or a chronic fracture, but we can't get an MRI. So in terms of treatment, bed rest is an option, not a very good one. Bracing is an option. Pain medication, analgesics is an option. Kyphoplasty is an option, and vertebroplasty is an option. And I'll get into some of those. Traumatic fractures, we're talking about non-osteoporotic fractures. Basically, those will heal typically in 3 months. The typical treatment is to put someone in a brace, and usually they heal without a problem. And you can see there's a fracture that's healed, but there's really not going to be any consequence from that fracture because there's no kyphosis or significant structural changes other than a little loss of height, and a healed fracture doesn't hurt. But if you have severe kyphosis, then you might need a corrective surgery, but that's a big operation once you have a healed fracture. So braces, you can see they're uncomfortable, they're sometimes painful to wear, they're cumbersome. Older people have difficulty with them, and a lot of people are obese or overweight, and it's very difficult to brace somebody that doesn't have good physique. It doesn't fit well, it doesn't work well, they slide up to their chins. And so we do that sometimes, but it just doesn't really work very well, particularly for osteoporotic fractures. So in terms of kyphosis, what is it? Kyphosis is essentially a forward curvature of your spine where your posture is pushed forward, And in the normal spine, you have a thoracic kyphosis and a lumbar lordosis, and that allows your head to sit over your pelvis and you to stand upright, which is the way we're designed to stand and walk. So if you develop kyphosis, it's typically an increase in thoracic forward curvature, and most commonly that'll happen from compression fractures. And as you get more fractures, you become more kyphotic. So, this is your classic kyphotic deformity and your old lady who has osteoporosis and has had multiple fractures that haven't been treated, and that's what you want to avoid. So kyphoplasty is what I do to surgically treat compression fractures, and it's a pretty simple procedure. It works very well. The reason we do it is for pain. So we're not doing it for nerve compression because that's typically not the problem. We're doing it because people have severe incapacitating pain. They can't get out of bed. They can't walk. And so what it involves is you make 2 incisions in the back of the spine for each bone, in the back for each bone. You put 2 large needles, or what we call osteointroducers, through the bone into the vertebral body from the back. You use a little drill through the osteointroducer to create a pilot hole. Then you put an inflatable bone tamp, which is a balloon essentially, into the osteointroducer, into that hole. You inflate it. It compresses the bone away. It really acts like a jack. It elevates the end plate and it reduces kyphosis to varying degrees in many cases. And it also creates a cavity. And then in that cavity, you inject cement through the osteointroducers, and that cement hardens immediately, and that stabilizes the fracture. And it prevents motion, and it helps with pain immediately. And the effect for pain relief is pretty dramatic in most cases and immediate. So it's a minimally invasive procedure. We do it under general anesthesia. It can be done under local or conscious sedation. It can be done as an outpatient procedure, but some people will often stay overnight, but usually it's on one night. We use 2 x-ray machines, biplanar fluoroscopy, to do it in the operating room or in the radiology suite. It takes about 15 or 20 minutes per fracture, and if you have multiple fractures, you can treat 4 or 5 at a time. So the advantages of a kyphoplasty are, number 1, you elevate the fracture and you reduce kyphosis. So if you catch everyone in a patient and prevent them from curving forward, they're not going to look like that old lady. The cavity that you create is a hole, and you can put thick cement in there, and the cement's like toothpaste, and it gives you control, so it goes where you want it to go, so it doesn't go out into the surrounding tissue or into the spinal canal or around the spinal cord or nerves, for the most part. And that's really very advantageous. But you can't do it for a healed fracture. Anytime a fracture is healed, then it's done. So if you have a kyphotic fracture that's healed, the only thing you can really do to fix that is to do a major surgical procedure, a lot of screws and rods, and usually that's not something you're going to want to do. But if you have an acute fracture with severe pain, it gives you dramatic, immediate relief, and that's what we're doing it for. So this is just some images that show you a kyphoplasty on the x-ray machine. So this is a lateral, not the greatest pictures, but this is a lateral image, shows you the deflated balloon going in from the side through the osteointroducer. The balloon's inflated, the balloon's deflated and removed, and there's a cavity created there. And then you put cement in, which will go out into the surrounding bone and interdigitate with the bone. And then from a front view, it's basically the same thing, osteointroducer and balloon, inflation of the balloon, inflation on the other side, and then the cavity you see very clearly there, and then the cement. So the alternative surgical procedures of vertebroplasty, and what that is very simple. It's just a needle that goes into the bone, and you inject watery cement into the bone. It's like water, right, Scott? I mean, it's the same consistency. So basically, there are trabeculae or channels in the bone that the cement will flow through, and it'll fill the channels, and it'll go into the bone and stabilize it. It doesn't elevate it. It doesn't change the kyphosis, but it does actually work very well for pain relief acutely. And most studies show that it's about the same level of pain relief from a vertebroplasty as a kyphoplasty, but you don't get the kyphosis reduction or increase in height. The big problem really though is that the cement is liquid. It's like water. You don't really have control over it, and so it's much easier for that to extravasate into the surrounding tissues, to get into the spinal canal, or potentially into blood vessels. But it is cheaper, and that's significantly cheaper actually, so that's one advantage. This just demonstrates kyphosis reduction. You have a 9-degree fracture here, which is elevated to 3 degrees with the balloon in place, and that's what we're achieving. That's what the kyphoplasty is good for. So complications, cement can get out into the surrounding tissue. It could compress the spinal cord. It could get into blood vessels. It could go to the heart or lungs. It's very uncommon for us to have that kind of complication, but it is reported. There may be toxicity with cement because it's a chemical, and in some people they may have a sensitivity to it. It's not fully understood, but it can cause cardiovascular problems. You could have an infection, which is thankfully very rare, and medical complications like a heart attack or blood clot, pneumonia. But really what we see a lot of is or not a lot of, but relatively frequently are additional fractures, and I want to get into that a little more in a minute. But if you compare kyphoplasty versus conservative treatment, this is a study of almost 6,000 people in a hospital inpatient sample. The discharge home versus conservative treatment is higher. The rate of discharge to nursing homes is lower. The complication rate is equivalent. That's actually not statistically different. And the in-hospital mortality rate is a lot lower. But the cost, again, is higher. This basically demonstrates the same things in a tabulated form. But so this is a guy that I did kyphoplasty on. He had several fractures. He had osteoporosis. And so I treated him. He developed this fracture. We treated that fracture, and then he developed another fracture above it. And so that's seen. And so initially when we started doing this, there was a lot of talk about the cement somehow causing the fracture. It's harder than the bone, and somehow that causes a fracture. But that's probably not the case. What really happens is the more kyphotic you are, the higher your risk of having more fractures. And so if you compare it to vertebroplasty, where the kyphosis level is generally higher per fracture, there's a higher rate of adjacent fractures with vertebroplasty. And if you have really severe osteoporosis, you're much more likely to have another fracture. But you can see here in this very kyphotic patient standing up that gravity is basically pulling their spine down and putting a lot of force on those bones. We see in people that have bad osteoporosis, sometimes they come and they say, I had the flu and I was coughing and I had this terrible pain, and that caused their fracture, which means to me their bones are really weak, as opposed to someone that fell hard on their back and they have a fracture from that. So if you have really bad osteoporosis, those seem to be the people that are more likely to develop more fractures. But the kyphosis is a big part of it. And so this just demonstrates that the more fractures you have, the higher risk of having additional fractures, and that is related to kyphosis. So decision making is very simple, for me at least. If someone has tolerable pain, if they're ambulatory, you treat them conservatively as an outpatient. If they're stuck in bed, they can't walk, they're stuck in the hospital, you can't control their pain, then generally you recommend a kyphoplasty. Bed rest is bad for people, and it's very bad for older people. You get bed sores and blood clots and pneumonias, and so that's a lot of the morbidity from fractures, actually. If someone has a severe kyphosis, you'd lean towards a kyphoplasty, maybe if there's less pain, because you want to prevent that from worsening. You consider their overall health as well. But so some things you can't do. If you have a vertebral plane, it's a complete collapse. You just can't get a balloon in there and inflate it, and it just doesn't work. So you can't do a kyphoplasty for that. If the fracture's healed, you can't do it. Or if you have spinal cord and nerve compression, you can do it if you do it in combination with a laminectomy or some other decompressive procedure, but not as a standalone procedure. So, but back to conservative treatment, most fractures will heal if you give them 3 or 4 months. But the risks are you may develop kyphosis that progresses as the fracture heals. Some people develop avascular necrosis, where basically there's no healing, and you basically have soft tissue there, and it just continues to hurt, and you continue to collapse. You can develop nerve compression if it collapses as it heals, and then once it heals, if you have a kyphotic deformity, you're stuck with it. So this just shows all the negative consequences of kyphotic deformity, which have been demonstrated in the literature, right up to excess mortality. And this is independent of the acute fracture pain. So once their fracture pain is gone and they've healed, that risk is still there because it's from the kyphosis. It's not from the acute fracture pain, or a lot of it isn't. So we think of this downward spiral of osteoporosis where you have a fracture, you develop a deformity, your lung capacity decreases, your chest gets pushed down into your abdomen, you have decreased appetite because of that, you have more pain, you have trouble sleeping, your activity goes down, your bone density goes down, you have more fractures, and ultimately it increases your mortality. So we want to obviously avoid that. And this just outlines the economic cost, which I think Steve basically talked about for other types of osteoporotic fractures, but it's a major cost. So the best treatment is prevention. You want to prevent osteoporosis. We see a lot of people come in that have had a fracture. They've never had a bone density. They're postmenopausal. They're 70. They never had a bone density. Or they had a bone density. You say, how's your bone density? You have osteoporosis? Oh, no, I had a normal bone density. When? 10 years ago. So, you know, it's got to be followed regularly. And if you have osteoporosis, you have to treat it aggressively. You know, that's up to, you know, the medical doctors and the endocrinologists, but it really needs to be treated aggressively, and a lot of times it's not optimally treated. Weight-bearing exercises, as Steve talked about, and the major issue really that we see a lot of is steroids. They're really a killer. People have terrible osteoporosis when they've been on steroids for any length of time. And so if there's any way you can avoid it, which is not always possible, you're better off. And that's it.